Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. Today on the podcast, I'm hosting Valeria Mulryne, who graduated with a Bachelor of Arts degree from Gettysburg College in 2003 and earned her doctorate of PT degree in 2006 from Arcadia University while also earning her certification as an athletic trainer. Valerie worked for 5 years at Marlton Rehab Hospital in New Jersey as an outpatient PT until 2011, where she created and implemented a cancer and lymphedema outpatient treatment program. Valerie has been a PT with MedStar Health Physical Therapy at ONI for 11 years, specializing in oncology rehab and lymphedema management. In 2012, she became the clinic's primary PT to treat those diagnosed with cancer, lymphedema, and vascular insufficiencies. In April of 2021, Valerie became a certified lymphedema therapist, and during her career at MedStar, she's been a clinical instructor in multiple cancer-related focus groups, including Cancer Rehab Team Rounds, Cancer Pod, Breast Cancer Tumor Board, and Cancer Regroup. In fall of 2022, Valerie was promoted to Program Specialist for MedStar Health Physical Therapy Cancer Program in the Greater Washington area. Valerie currently serves as MedStar Physical Therapy at ONI's Wellness Coach and has training in Reiki and craniosacral therapy. In May of 2022, she was awarded the MedStar Health Physical Therapy Outpatient Safety Award. I am really excited to host Valerie. She is very passionate about cancer rehab. You will hear it in her voice, so let's go into it. Good morning, Val. How's it going?
It's going well. It's a beautiful cloudy day here in Maryland, so I'm just excited to share some information and get to talk to you about cancer rehab and how I can maybe help other clinicians within MedStar.
Yeah, I'm really excited to get the word out about this topic more and get more PTs comfortable treating this patient population. And in a couple of days, it is Cancer Survivor Day. And I'm really excited to drop an episode with a few patients who are survivors to share their stories, but I thought it would be good to kind of have a conversation with you first and learn more about cancer rehab. But before we jump in, I like hearing people's stories. How did you get into physical therapy, and then why cancer rehab specifically?
Sure. So my whole life, even as a little girl, I always thought I would do something medical. And when you're growing up, you either know, as a 4 or 5-year-old, as a pediatrician or a dentist, and respectful to all the dentists out there. Who the heck wants to be a dentist? So with that in mind, I just always found the human body fascinating, even as a little girl. And so going from a small community of, 54 graduates out of an 8th grade class to a 9th grade class of 530 people as a sending district, I started playing sports, but it was just too much boot camp for me. And I just really loved the sport, but didn't want to be treated that way. So eventually I turned to the world of athletic training. We had an athletic training program where the students could become kind of the right hand of the certified athletic trainer, working with the teams, learning to stretch, learning modalities, learning the human body. I learned how to tape every body part possible. And during that time, I ended up accidentally having an injury to my nervous system. I have a reflex sympathetic dystrophy in my left foot. And at the time, in about 1997-ish, my symptoms started after a kick to the inside of my ankle area on my left leg, playing indoor soccer. And nobody knew what the symptoms were. And I went to about a dozen different doctors. Long story long, eventually one of the professionals at, I think it was Children's Hospital Philadelphia, actually put me in a CAN boot and then followed by a cast for a total of 7 weeks. And my pain just worsened. And I ended up atrophying. And while I was student athletic training, I entered the world of physical therapy once the cast came off for 8 months. And so I spent 2 to 3 times a week for 2 hours a session for 8 months in the pool and on land, and realized that the world of physical therapy is very similar to the world of athletic training, which I was already loving. It's just a different environment with some different fun tools and fun things to do. So I just didn't know where I wanted to go at that point, either, join the athletic training world or go physical therapy. So when I went to college, I picked Gettysburg College, where I was a health and exercise sciences major, and I was able to spend time in the athletic training room as a student, Back then, they had an internship program. So you had to spend so many hours, and then you could sit for the exam and become a certified athletic trainer. And after I did that, I immediately graduated from Gettysburg and went right into physical therapy school at Arcadia University outside of Philadelphia for my doctorate. And while I was there, I was able to athletic train in the athletic training room at Arcadia and then also do some per diem work. So physical therapy wise, I think it was just meant to be kind of my path between athletic training and physical therapy. And then so while I was in school at Arcadia, I had one class that really turned my interest into lymphedema and cancer rehab. As most physical therapy programs, whether it's an assistant or physical therapy, you really don't get information on lymphedema and cancer care in terms of rehab. And I had just a very dynamic physical therapist come and speak to us with the lab. And she just made it seem like I could heal every woman, women's lib, let's get them back, not lying in bed for the rest of their lives. And so I spent 10 weeks with a rotation with a clinic instructor who treated cancer, lymphedema, vascular insufficiencies, and orthopedics. And so there began my journey in the cancer world.
Well, I'm glad that this has landed you here. Not that you had to go through that, but I'm glad that you landed here because, again, this is a really important topic that I want to cover with you. And I know that you kind of spearhead with another clinician in our network, the cancer rehab specialty. So can we get into that, kind of the history of that and what is involved with cancer rehab, wherever you want to start?
Sure. So I've been treating cancer rehab again as a student. And then after graduation, I went to go work with my clinic assistant to continue that mentoring. Unfortunately, that didn't last long. She left the practice and I was pretty much alone and not knowing all those red flags. So at my next job, I spent some time just taking continuing education for about 2 years, both in the world of cancer and in the world of lymphedema, and asked to open my own program there. And so that came to fruition. I left there, moved to the DMV area for love, really. My then boyfriend got a job with the government down here. We're originally from New Jersey. We're living in Philadelphia at this time. So when I came down here, I was really supposed to be treating ortho and sports med. And after a year of being hired in the Olney site, the woman who was spearheading the cancer program there left to go into a private practice. And so they asked me with my background if I would take it over. So about almost the last 11 years, I've been working in the cancer population, even though I only just got recently certified in lymphedema management in April of 2021, I believe, but I was treating it this whole time. And so with my history of an experience, both back in New Jersey where I had started this program, as well as my experience here in MedStar in Olney, I was asked to apply for this new clinical specialist program that is involving the cancer rehab across the network. And so I interviewed, I applied, and so I had the wonderful just offer to have to take over that position, of which I have help from Dave Federline up in the Baltimore area, who has just partnered with me beautifully and has become a great mentor, helped me get into the ropes of things. And then we also have a wonderful therapist in DC by the name of Yvonne Francis, who is Dave's my right hand guy and Yvonne's our left hand. And so we've been working together across the network to really bridge the gap of PR advertising that we promote and offer cancer rehab, when really it's very sparse throughout the 50 some odd clinics that we have in MedStar itself. And so we've been trying to it's been several months. It hasn't been very long at all, but to try to bring education across the network to our outpatient facilities, beginning with breast cancer, giving in services clinic by clinic, offering continuing education opportunities. Dave runs a really great cancer pod that we're opening up now to speech therapists, because we're starting to go into a head and neck cancer program of education, because we really need to treat this huge population of not just breast cancer, but intestinal cancers and, all different head and neck, throat cancers, facial, any type of bone cancer. We really need to be able to educate our clinicians and to compete with those hospitals and facilities around us, because not only do the patients need us, but we could really bank on that too, is the way I kind of present it. So we've been really working hard to slowly get things organized so that way everybody's on the same path and everybody's not scared of that C word, and that realizing that patients aren't so fragile, and that if you're orthopedically minded or neurologically minded, you can kind of think of it in treating this population in that manner. They just happen to have cancer alongside of it, so it's not so scary.
I want to get into eventually patient gets a diagnosis. What does their course of treatment look like? Who do they encounter? But first, I'm curious the evolution of how you've seen cancer rehab progress, I guess, since you've been doing this, because you've been doing it a while. Like, are doctors on board? Are they referring patients to you? Or are you having to educate them on what we do? How does that relationship work?
I think it's different across the board. I think that I'm very fortunate right now. Most of my population is with breast cancer. So I have a fabulous medical team over at the hospital. I'm at MedStar Montgomery Medical Center and only, and the breast surgeon there, Dr. Jennifer Sun, and the plastics, Dr. Jabor, and the medical oncologist. They all work as a unit. And then they have this wonderful nurse navigator by the name of Kathy Brophy. And so we literally just have this flow. And it wasn't hard to build that, really. Dr. Sun came on board maybe about 2 years ago, and she said, I want to start this prehab program. Our patients need prehab, just like they would if they were having an ACL reconstruction or a shoulder surgery or whatever, to get them in the best shape possible, to get baseline measurements for when they come to you after surgery. You can keep track of who they were before, where they are after surgery, and where can you get them back. And it has just worked beautifully. So I'm very thankful, and it's very easy that I have that relationship with that particular team. I also have a team outside, because we have other surgeons specifically with breast and oncology on the campus that are not MedStar, that I also get referrals from. And I think that's probably more of a PR, or just frankly, because I'm really the only one in the area who does this until Dave Avon and I can get that word out across, and hopefully it'll spread out to other sites. So I think my situation's a little bit differently, whereas other sites I've been going to, they don't have the referrals yet. And so we're going to work with that with the PR team and see, once they're trained and the call center has breast cancer rehab next to each individual therapist's name, that they are now comfortable treating that both prehab and post-hab, that we'll be able to PR that a little bit more and get the physicians on board, let them know that, hey, Ellicott City now can treat this, even though Ellicott City doesn't know yet who the physicians are. And to that note, we are trying to put together a directory of physicians in the oncology world that the MedStar as a whole, from Baltimore down to Southern Maryland, from Prince George's County to Virginia, will have, so that way we know who we can go to if there's a problem, if we have a question, who we can reach out to for PR as well. So I think each area has a little bit different, especially those like Dave at Good Samaritan has a great team, and he is very close because it's a hospital system right there. But if you stand alone, it's a lot harder, and that's what we're trying to minimize as we grow in this cancer rehab world.
I love that you brought up the importance of prehab, because we do it for so many things, and it's a great time for the patient to get to know their therapist, to get comfortable in the clinic, so that there's not so much new after a very big hardship going on in their life.
Exactly. And one of the things that we're really trying to teach the therapists across the network with prehab is, this is not a chance just for the therapist and the patient to get to know each other on a more intimate level, because these women in particular with breast cancer, their bodies are changing, and they have emotions and anxieties, and they're having fear. And how do they take care of their 3-year-old, and how do they take care of their husband and run a household, and what about their job? And it's a lot emotionally and mentally. But it also, they have so much information bombarded at them from their doctors. And so they get this huge booklet, but this is a time that we can answer questions on a more calm basis in a private manner, about their surgery, what to expect after their surgery, what to look for in terms of infection, lymphedema, what does a drain mean? What do you do with that? And so they have a great number of questions that the doctors can't always answer right then and there, or the patient doesn't think about it as they're being told they have this mortality that they're looking at now because of potentially with whatever cancer they're diagnosed. So in addition to getting the information I need, they get more information that will help them. And we talk about relaxation and meditation and trying to bring their anxiety down. And it's not just about a physical therapy level, but it's also about just a generalized well-being level as well on the mental and emotional aspect, which takes some time to learn, but we're willing to teach it and get that education across so people are more comfortable having those conversations.
Definitely. Yeah. You bring up a good point. We go to the doctor and we're healthcare practitioners, and I leave with a million questions. I'm like, shoot, I forgot to ask all that.
Yeah.
So bridging that gap and having that communication with your PT, and that, having that communication beforehand is so helpful and so
Yeah.
imperative. It can be information overload too.
It's
Um,
always information overload. And so
yeah.
that first time I give them my card and I tell them, I kind of joke, I say, well, I'm an Aquarius. So once you're on my team, like I'm one of you. That's one of our things is, we're bonded for life now. And I said, I'm always in your back pocket. Email me, call me with questions. If something arises, you can't get a hold of the doctor, maybe I can help you. And if I can't help you, then I have that communication with the surgeon that I'm so close with to be able to get you help.
hmm Can we jump into patient goes to the doctor, gets that diagnosis? Where does it go from there?
Oh, so their journey is a lot longer before they come to see me typically. So they go through a whole bunch of testing. They go through a whole bunch of just preparation for what they need to be able to decide. They have to decide on, first they get a biopsy done. They might even have a little bit of a testing to see has that cancer spread. So they have to do a whole lot on the medical side, and they need to decide based off of their testing with their surgeons what kind of surgery do they have? Do they have a partial mastectomy, otherwise known as a lumpectomy? Do they have a full mastectomy? Are they having reconstruction of any sort? What kind of reconstruction? Like, what is their game plan? Do they have to go and potentially have chemotherapy beforehand? Are they planning on having chemotherapy after radiation? And sometimes those answers aren't found until their surgery. And so
Mm.
that can be a little bit, oh my gosh, I don't know what's going on there either. So pretty much once they have a surgery date, at least in my world with Dr. Sun's group in particular, then I get a notification or the prescriptions loaded up to MedConnect, and my admin team will contact me so I can find them a prehab spot. And so I evaluate them at their prehab. They have done better at this. Sometimes that prehab evaluation, unfortunately, is a week's notice before their surgery. We've had that conversation of give me some more time, especially if at prehab I find they don't have really great range of motion, but it seems like they might have radiation afterwards. We want to, just like an ACL reconstruction, get their range of motion back as fast as possible beforehand, get them as strong as possible beforehand, get their endurance up as much as beforehand. So if we see that, we can see them a couple times or work on a home program. But most cases, 99% of my patient caseload, I don't have to keep them. It's an eval, information overload, give them some exercises maybe before surgery, maybe some exercises that once they're cleared after their surgery by their surgeon, but they still have maybe like a week delay to get to me, that they can start on. So once I see them for prehab, I pretty much set them up right then and there for their post-hab evaluation. Usually it's about 2.5, sometimes up to 4 weeks later. I aim for about 3 to split the baby, if you will. And if there's a complication, then the patient and or the doctor will reach back out to me and say, hold off, so much time. My system's a little bit different probably in that if I know someone's going to have a surgery on a date, I will then call them. Usually about 2 weeks, they have to go in for their their post-operative checkup with the surgeon, whether it's the breast surgeon and or plastics. I will call that person and say, hey, are we still on board for next week at whatever day and time? If they're not, then I can push that evaluation. If they are, great. You already have that date and time set up. I'll see you then.
And then that communication comes in handy, having known them beforehand. You're checking on them, which I'm sure they appreciate more than anything.
Yeah, they actually are pretty impressed that I'm calling them or emailing them, however, to communicate and say, how are you doing? Are you doing okay? Can we move forward and get you in as soon as possible? What was great actually was just last week, I was able to shadow Dr. Sun in her office. And so one of my patients who had just finished surgery with her and having plastics, I was able to see her at post-operative in the clinic, which is a lot different than in my office, and set up the appointment right then and there for her post-operative. So that was really helpful. I'm hoping to continue that somehow with her.
Yeah, that's amazing. I I can't help but compare these things to ACL surgeries
Yeah,
because that's a lot of what I treat.
sure.
And
I used
we
to
know,
too.
yeah, and with that, getting them in as soon as possible, even total joints, patients post-op total joints, get them
Yeah.
in as fast as possible, get them moving. How quickly and what is the importance of getting someone who has been through a surgery in quickly, but what are also some precautions with regards to like wounds and stuff and trying to range of motion and all of that?
Yeah, so just focusing mainly because I see breast cancer, and I think that's what our team has been focusing on lately. And we're talking about breast cancer survivorship coming up. So, your wounds are going to be wounds, whether it's a knee, an ankle, a shoulder. So, just looking for signs of infection, making sure everything's really clean, nothing's draining too much. Typically, these patients are still coming with steri strips, just like they would after an orthopedic. So, just educating them on how to care for those steri strips. By the time I see them, they do not have their chest drains in anymore. So I cannot see them until they come out, which sometimes can hinder. If they're still draining at week 3, then we have to push it to week 4. So we talk about signs of infection. We talk about signs of lymphedema. But those things we're also talking about at prehab, and then
Sure.
we're reviewing at their post-hab evaluation, just for clarification and reminder. So in terms of, after when their drains are in at prehab, we're talking about their precautions with the drains. No reaching overhead, so nothing over shoulder height above 90 degrees flexion or abduction. No driving, especially if they're on opioids or some sort of hard drug, and no lifting over 10 pounds. And that's pretty much until the drains come out. Once the drains come out, it's really about just listening to your body. They really don't have precautions except for lymphedema precautions. So if in most cases they do take out or they biopsy some sort of axillary lymph nodes to determine if there's cancer present and has spread via metastasis. So if they have an axillary node dissection, their risk of lymphedema is a lot greater than if they have what they call a sentinel node biopsy. So at the time of surgery, if they're having a sentinel node biopsy, a couple days before, they'll go and inject dye local to the tumor and see where does that dye get sucked up? What lymph node or lymph nodes does that dye go to? Because those would be the ones that would receive the cancer first if there was metastasis. People who have that, their risk of lymphedema is lower than if they had an axillary node dissection where they're actually cutting out nodes. The more nodes that are cut out, the higher risk you are having lymphedema. So we talk about that quite a bit. If they have to have, a sleeve, we take measurements to determine their girth volumes and girths, and therefore their volumes of both arms to see and keep track of lymphedema onsets. So we really start off the first several weeks mostly working on soft tissue, scar mobilization once we're able to, soft tissue mobilization, joint mobilization of the shoulder. So the way I teach this is you have a shoulder patient. That patient has rotator cuff, impingement, whatever the case is, and they're stiff. How are you going to work them? So if you're going to go from, working on scapular mobilization, that's great. If you're going to work on active range of motion, passive range of motion, active assisted range of motion, you're going to work on scapular stabilization and posture and all those things, just like you would with a patient with a shoulder problem, an impingement, a rotator cuff, a labral tear. It might not be that you're starting off with 5-10 pound weights, but you wouldn't be after a shoulder surgery either. So you're really working the same thing, possibly with more focus on edema in the breast and in the arm with incision mode, lines. The edema will reduce post-operatively within a few weeks, just like it would with a knee replacement and ankle surgery, any sort of insult to the skin. But if it stays and doesn't go away, then you have to consider lymphedema. And then that's another whole world that you can talk about and I treat. Not every therapist will. But for therapists that don't treat that, you would then refer back to the doctor or refer to somebody like me who can treat. So it really isn't that much different. That second month, we might start working much more on higher level functional tasks. So I'm hoping within the first, say, 4 weeks, I have their range of motion back pretty much full. We don't want to create an adhesive capsulitis situation because then it makes it even worse and much more challenging, as everybody knows who treats adhesive capsulitis. It's just more painful. It's just longer. It takes forever. So we're trying to avoid that at all costs. Obviously, we're working on cardiovascular things, a UBE for arms, or if that person just enjoys walking, but they just can't walk their 3 miles a day at 5 miles an hour, you can still put them on a treadmill, but they're going to walk slower. I encourage people, especially now that it's spring, to get out and walk to build their endurance. They need that sun, that energy, not just sit in bed all day, which it was 20, 30, 40 years ago, even more, to go home and sit in bed the rest of your life. And so, as therapists, we don't want that to happen.
Two questions
Yeah.
that came to mind with the nodes and whether they remove or don't remove or do the dye procedure. Is that,
Mhm.
I know you have a good relationship with the doctor, but otherwise, is that typically noted on the script from the doctor whether they had a specific procedure or not, or is it more general?
So basically, because the prescriptions, especially through MedStar, come through MedConnect, they use the codes. And so that it'll have some sort of Z code or S code or whatever the case may be. They may in the notes write it, or especially on the prehab, if they know that they're going to have the sentinel node biopsy done a couple days before. They'll put the dye in a couple days before and then check to see at time of surgery how far did that dye go, where did it go. They might write it in there as a comment, but there's not a ICD-10 code that they will put on the prescription for that.
Okay.
Most times the patient knows at least what kind of procedure they had. They probably don't always know how many nodes were taken out of a dissection or how many were positive, and that's where having that connection to the op report would come in handy.
Yeah, and if you're treating a patient that is not from a MedStar doctor, then it's important to call the doctor, get the op note, and see exactly what was done, because we can't always rely on our patients to tell us what they had done as well.
Yeah, you absolutely can. In the greater scheme, if somebody has 18 lymph nodes taken out versus, say, 4, it's helpful to know. But either way, you're still looking for signs of lymphedema, talking about symptoms, keeping measurements, either girth measurements, volume measurements, however it is the therapist decides to watch that. In terms of precautions, I also forgot to mention lymphedema precautions. So the research behind lymphedema precautions is not very good, but generally I tell people, it's your body. If you were my sister, my sister-in-law, my aunt, my mom, things you might want to be careful of is blood pressure cuffs to the affected arm where the lymph nodes were removed. So, try not to do that. Or needle sticks to either give or to receive. So either injections for vaccinations, or to take blood out would be preferable on the other arm, assuming that you are only having this done on one side. If it's done on both sides, sometimes that does happen, or 20 years later, whatever the case may be, somebody might get cancer on the other side and those lymph nodes have to be removed. Then I would consult the doctor as to what would be the more ideal arm to use for those such things. There are rare phlebotomists that will take blood from your leg or foot, but you have to find them as needed. And of course, as we know, you can also do a blood pressure, which might not be as ideal from the leg. Um, but it's something to consider. And I also talk to them if they want to get a medical bracelet for lymphedema precautions, just like somebody who has seizures or diabetes might have, in case they can't speak for themselves and they have to be in the hospital or medical situation. So I forgot to mention that.
You spoke about the fatigue, and I'm wondering, I know obviously the medication fatigues you, the procedure fatigues you. What kind
Yeah.
of tips do you give patients who are combating fatigue, and how do you know when it's like there's two levels of fatigue? There's like the medication fatigue, and there's just lack of movement also makes you tired. Where's the
Yeah.
line drawn between pushing them but not overdoing it?
Yeah. So, honestly, again, relating it back to the orthopedic side and the sports medicine side, I get this question a lot when I do my in service. Like, how do I know how hard to push these fragile patients? How would you know how far to push your athlete? Right. So I would say that the fatigue from the drugs isn't as much, except for the chemo. Like if they have chemotherapy or they have radiation, they're going to have different types of fatigue. But if it's the long-term hormonal drugs that sometimes they go on, they're not going to be as fatigued as maybe chemotherapy drugs might instill, or radiation even. If you're having deconditioning just because you're kind of lying around recuperating, what I usually tell people is, in any case, just try to go for some walks. If you used to be a walker or you just used to go to the mall or the supermarket, even if you can just be in your driveway doing laps, or if that's too much, go in your house and go around the dining room table. Start with a couple minutes. When you feel like your body is telling you, I need to sit down, then go ahead and sit down. I don't want you to go to bed. I don't want you to necessarily take naps unless your body is really needing it. but just go take a rest. And then later on in the day, try it again. And then you try to increase those repetitions. And then instead of the dining room table, maybe you can then go in the driveway. And then once you're in the driveway and you feel like you're getting bored of that, then see if you can go a house or two down, or maybe 5 houses down. Take your phone with you, or make sure you're with a family member who might have to come back and get you, or you call that patient. But it's just like you would with an athlete who's getting, training to get back from a surgery or just an injury, of just listening to your body, slow but steady. I think the big message is again, 20, 30 years ago, people would be told to stay in bed, or even 100 years ago, if you think about it, they wouldn't move at all. So it's important to say, look, the first couple days after surgery, okay, like if you need to be in bed, that's fine. Try to get out and go sit in a chair, just like they would in a hospital setting, right? So just try not to, if bed is for sleeping, try to get up, try to move around. When your body is tired, take a rest and listen to your body. And then as we progress in physical therapy with cardiac exercises, with strengthening exercises, you can actually see in their faces when they're tired, watching their eyes. That's the biggest thing. When they're just sunk and they're like, oh, I need to sit down, get them some water, let them take a break. When they say they're done, they're done. But otherwise, if they, and I always kind of ask on a scale of 0 to 10, 0, you could do this all day. 10 is you want to run away from me screaming. Like you kind of want to be in that sweet spot of maybe like a 4, 5, 6, and then be like, okay, that's enough for today, or give them a rest and see if they come back down.
Yeah, that makes a lot of sense. You were going through the progression of regarding like when a patient starts and then getting your full range of motion back. What is the typical length of course of treatment for a patient with cancer post-op?
Oh, it's just so different, just like with anybody. If they have setbacks, if they have infections, then they have to get, go in with IV antibiotics, or they have to put therapy on hold. If they have something called a seroma, where this pocket of fluid happens and then they have to get drained a couple times, or if a stitch pops open and they have to go back in. But typically with my breast cancer patients, I see them maybe about 6 to 8 weeks, twice a week. Now, at some point during that second month, I try to dumb them down to once a week, as long as they can tolerate it. The first month is mainly posture, range of motion, manual therapy, gentle scapular postural exercises, some maybe TheraBand work, light 1-pound weights for shoulder flexion, shoulder abduction, yellow, red bands, maybe up to a green for internal, external rotation, rows, suitcases, pulley work. Stretching the pecs is a huge thing. And then that second month is primarily like, what is it that we need to get you back doing? You're too afraid to lift and carry that heavy laundry basket? Okay, here's a crate. Let's add some weights to it, gently, slowly, let's go and do it. You're having a hard time reaching that 2 plates up to that counter, or up to that overhead shelf. Well, then let's focus on giving you a heavier weight and trying to do that in a cabinet system. So it's really more functionally based. I do have patients that sometimes last longer. So that also depends on the chemotherapy that they've had. If they've had chemotherapy, how that responds to them. If they've had some experimental drugs, I won't say her name, but there's somebody that you talk to for your survivor cancer pod. I know she wouldn't mind me telling you that I worked on her endurance, her strength for about 8 months, because she was so sunk from the clinical trial that she went through with her chemotherapy. So it just depends on it's patient dependent, as with anybody.
Yep, that's a good plug to tune in a couple days to hear that podcast and hear her story. When we were speaking beforehand to prepare for this podcast, I was amazed with the amount of people who are on the team for when a patient has cancer. Can you tell us, you don't have to go into everything that everyone does, but even just who makes up the team for a patient when they get that diagnosis?
Oh, I'm not even sure I can touch on all of them. Again, using Dr. Sun's office as an example, they have social workers that are fantastic at getting them resources before and after. They have a survivorship program where so many months, weeks after their surgery, they follow up again so many months later. What can I do? What do you need? Do you need a support system? Do you need a vendor? Do you need mental health, whatever the case is? So they have that in store, and they are literally with them. So if I have a patient who I just know is depressed or having anxiety because of this, I can reach out to those social workers. And I've asked the patient, may I reach out to Erin at Dr. Sun's office and see if she can help you, or whomever. Samantha is there as well. So a lot of times they'll take my referral and they'll call the patient to check in, which is great. There's the breast surgeon, there's a medical hematologist, oncologist, sometimes just a medical oncologist, there's radiation oncology. Who else am I missing? There's nurse navigators, there's plastics. So there's definitely a huge team. And then you're talking not to forget, the administrative team that has to look for these prescriptions on MedConnect and help me to schedule patients and call patients. There's me, myself, and there's my clinic assistants. For a while, I had my own kind of right-hand PTA, but unfortunately she has since left MedStar last 8 months. So I've been more on my own, but that team member is really helpful because we could co-treat sometimes, or if we just needed a patient to be rewrapped off the cuff with lymphedema, I could say, hey, do you have room for Mrs. Smith for 15 minutes, and she would help me do that, or whatever the case is. So then if you have somebody, say, who has head and neck cancer, well, do they need speech therapy? Or even somebody who has chemo brain, do they need speech therapy for cognitive help? Do they need help with swallowing? Do we need to get OT involved because I have so much on my plate with that patient during my session, I can't get to chemo-induced peripheral neuropathy or the tendonitis they're getting in their hands and their joints from their long-term hormonal medications. So you can go the whole gamut of MedStar, and including their primary care. Forget that. We can go into primary care to communicate with too if there's something going on, or just to notify the primary care. By the way, your patient had cancer, they've gone through this, but now I'm seeing that, to just update their files. So really, I don't know if there's a stop point within the rainbow of the MedStar system with the medical team and going into rehab and that connection.
Yeah, other ones you had mentioned before are nutrition counseling, genetic counseling, nurse practitioners. So yeah, you're right.
Thank you. Yes,
a laundry list.
What I mean, there's so many. Yeah, so nutritionists based off of between the obesity, not eating because of chemotherapy, or just the healing process, being depressed. The mental health aspect is huge with this patient population. Some of them really are interested in alternative forms of medicine. So we have practitioners we have contacts with for Reiki, acupuncture, massage therapy. There's support groups where they actually, at the MMMC, where a woman who's gone through these breast cancer treatments can have like a pamper day where they learn to put on, they sometimes lose color, they lose their hair. So how do they pick out, say, the right wig, or how do they put their new makeup on that maybe they didn't know how to do before, or their colors have changed to make it look so they're healthier and they feel better and more feminine. So you're right. There's so many people outside of just the normal medical spectrum, but resources around. And then you're not even missing the vendors. So if you need a compression garment, if you need a vasopneumatic device to combat lymphedema, there are those people too that help. So there's no end.
I hope this has sparked interest in physical therapists out there and PT students out there to learn more about this. But is there anything else we didn't touch on that you really want to talk about regarding cancer rehab, PT getting into cancer rehab, anything? The floor is yours.
Oh, well, so I know I touched a lot more on breast cancer specifically because that's mainly my population. And again, with your podcast coming up with the survivors, I thought that was really important. But I'd love for myself, my team with Dave and Yvonne to really get into meeting with you again to talk about other cancers and how that is similar but different, because we're going to start that spread across the network in terms of education and getting our patient or our therapist ready to treat, whether it's reproductive cancer or, head and neck is really where we're headed next. I would love for therapists to come shadow us. So we're not allowed to have a mentorship program per se, but we are offering shadowing between Dave and Yvonne and myself. We have other seasoned therapists that I know want to help grow this. They're part of our cancer pod. So whether it's PT, OT, speech, we can find somebody for you to come and shadow. You don't have to come all the way out to Olney if you're in Southern Maryland or whatever. I've done Teams meetings with people and coached them that way at the spur of the moment because I had a patient who was cancer. And oh my gosh, how do I manage? So we can help you with that. So please don't hesitate to reach out to any of us. whether it's email or Teams, or in my office, we use the messages red dot system on WebPT, which no other office seems to use, but it's there on the dashboard and other pages of WebPT. So I would love for that. We've had students that will shadow Dr. Sun, again, breast surgeon and only, and I think she also goes down maybe to Chevy Chase or Georgetown. She's had a student come in and do clinic time with her. I shadowed her. Now the ORs are opening up, so I'm hoping that we can get into the OR with her. So there's so many opportunities to just further your education. Unfortunately, because schools don't offer this, it's upon us to get into the schools, which is one of my ideals for our cancer specialist program. Can we get in there and have somebody influence students like I was influenced in a 2-hour lecture with a 2-hour lab and get the help that we need? I'm hoping that we have our education, continuing education. We just had one course this past weekend. Dave is putting together a really great dinner with the doc for September that's going to have a board of oncology physicians up in the Baltimore area to get information about and how to treat this population, what they see, what they expect, to have PR help and get us bridging that gap between the doctors and the therapists, for us to educate the therapists so they feel comfortable. So there's a whole bunch of stuff coming our way that I think will be really great and inspiring. But I think it's really important that even have a little bit of interest, or if you know somebody who is interested in joining the MedStar team in cancer rehab, we need help. In Montgomery County, I think there's 8 sites, give or take, and it's Valerie and only. So that's why it's so important for us to get out and educate the rest of you. Wheaton helps a little bit. They have a little bit of experience, but we need everybody on board to really hit this population, because they have nowhere else to go but outside of MedStar if they're lucky. And if you're interested in lymphedema management, I'm hoping that we can bring lymphedema also back to the network. We had that years ago, and now we're hearing that speech therapists are interested in also being able to treat lymphedema in the head and neck cancer world. So we're trying to really not just make it a PT problem, but also to make it across the therapist rainbow problem, and then bridge that gap again with the physician. So we're really trying to make this not just a national rehab MedStar physical therapy issue in physical therapy itself. So please call us, reach out to us. We won't let you down. So just ask what you think are stupid questions, and let us help you, because we need the help too, and so do the patients.
Yeah, if anyone is interested in doing any shadow time or wants to hear more, you can email us at ptpodcast@medstar.net, which should be in our show notes as well. So please feel free to reach out, and I can get you in contact with anyone you need to be in contact with.
That would be amazing.
Sweet. All right. So we like to end our episodes. I like to end our episodes hearing your favorite quote. So what is a quote that moves you, drives you, inspires you?
Okay. So I don't have really one. I used to grow up like watching movies, and I know like every word to Back to the Future Part 1 kind of a thing. But after the last time we had talked and you had invited me to do this, coincidentally, a friend of mine sent me a couple of quotes from Bryce Harper. So for those of you who don't know, I'm a Jersey girl, but I'm a huge Philadelphia sports fan. You can see I was drinking out of my Super Bowl cup that my beloved Eagles lost. We don't talk about that. So Bryce Harper, for those who aren't as familiar in the sports world, was this really young phenom, drafted into the MLB at quite a young age, played for the Nationals for a long time, and then came to my Philadelphia Phillies. And so he's actually coming back tonight from Tommy John surgery, the fastest recovery in MLB history at less than 160 days. He's going to play first base instead of right field. So we're very excited. So my friend sent me this huge long quote. And basically the background is Bryce is talking about his background. He was this kid, I think in the Las Vegas area he grew up. He was a phenom as a teenager. In high school, he was playing for a junior college, and he was expected, and all the pressure was on him to step up and be drafted at such a young age. And so he's talking about, where he is now compared to where he was before. And I will quote him here, which I thought was very appropriate for therapists in general, because I think this is what we live for. And Bryce, I never thought was an articulate guy, but this I thought really kind of hit home with me, and I think it'll hit home with therapists. So I'm going to read from my phone. He says, "So these moments are just so much fun for me. This is what it's all about. This is the game that we play. And so when that happens, you're excited, you're ecstatic, but you're so excited for everyone else around you as well. You're making things happen for everybody else around you. It's so much fun. It's what you dream of. This is what I love. This is what I do. End quote. How perfect. From Bryce Harper.
You gave me the chills, because when I'm in clinic and we're helping people, it's like the best thing in the world. I go home and I'm just on cloud nine. So that's amazing. I love that quote.
Grow,
yeah.
And especially in the cancer world, they're looking kind of through that tunnel of potential death and dying. It's a very scary diagnosis to have. And they come to you and they're full of fear and anxiety and stress. And they're looking down this very long, several years of a dark tunnel, because it's not like you just get surgery and you're done. And some people you are. But for most of the population, it is years of this dark, never-ending tunnel. And so you have to celebrate those little bits every part. You had your surgery, great, well done. You're going to have your chemotherapy. Some places they have like a chemotherapy bell you can ring. You celebrate with that patient. You've done radiation, well done. Now what's the next step? And so you take every moment and you literally watch that person go from being this inside themselves, scared person looking down this deep, dark tunnel and watching them step through every part to get better and better, to rise up. You are helping your patient to rise up. And by doing so, you are rising up. And it's wonderful. And again, I know she won't mind, but that one particular patient that you interviewed, she could not walk and move, could not. She, in the 6-minute walk test, she walked 70 feet. She was so zonked from her drugs. And I worked with her for 8 months, and she could stand in the shower and she could do some cooking and she could do some cleaning. And we legit, on her discharge day, I brought in my wedding veil tiara. We dressed her up with TheraBand as a corsage, and we had a party. And that's what makes it, to see those babies grow in front of you and see them get their life back. How awesome is that we can do that and be part of that process? It's amazing, and it's great for them and it's great for us. So Bryce, thank you for inspiring us.
I'm pumped. Let's go.
That's right.
Val, this has been absolutely incredible. I really appreciate you spending some time with us to spread the good word. And I would love to do another episode on another type of cancer and how we can help those patients. So thank you so much.
My pleasure. Thank you.
Since this podcast is coming a little bit after Bryce Harper made his debut, I do want to update you that he did go 0 for 4. However, he did return the quickest post Tommy John surgery. So just had to update you on that. Thank you for listening. Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.